Hello everyone, my name is Marcel Marchiori Farré, and together with my colleagues Rodrigo Matos de Souza and Henrique Teles Oliveira, we are responsible for the article entitled Orthodontic Treatment of Unilateral Cleft Lip and Palate Associated with Upper Canine-Premolar Transposition, a crazy report. This patient was treated at the Foundation for the Rehabilitation of Craniofacial Deformities, Fundef, located in Lajeado, Rio Grande do Sul, Brazil. When we talk about cleft lip and palate patients, it's important to know that it's a congenital malformation originated from the absence of fusion of the palatal process, even during the embryonic development. And it's also important to know that it has a high prevalence, with an occurrence of around 1 to 1,100 births, being therefore the most frequent craniofacial anomaly. Besides, it's important to know that in patients with cleft lip and palate, the presence of major occlusal chains, such as anterior and posterior crossbite, is very common. In addition, it's common to observe the absence of the lateral incisor in the region of the fissure, and an important planning decision is whether we will close the space with orthodontic treatment or rehabilitate the space. Another common occurrence in this case is tooth transposition, usually occurring between canine and premolar in the cleft region. Also, in this situation, there is an important decision to correct or to accept the transposition. In this context, is presented in this article a case of a 9-year-old patient with left unilateral cleft lip and palate who presented a good facial pattern and an aesthetic impairment in the smile due to the presence of the cleft and the occlusal consequence resulting from this problem. In intraoral analysis, it was possible to observe the presence of an anterior crossbite, posterior crossbite on the left side, midline deviation, cant of the occlusal plane, the absence of the lateral incisor that was confirmed by radiographies, the transposition of teeth 23 and 24 that was also confirmed and identified on the panoramic radiography. In the treatment plan, it was decided to accept the transposition, perform a slow maxillary expansion, and later secondary bone graft. The tooth 15 would be extracted in the upper arch to obtain space, and a mini implant would be used on the left side of the upper arch, helping to close the space by mesialization of the posterior teeth. In the upper photographs, it's possible to observe the progress of the treatment after the slow expansion of the maxilla, after the bone graft, and during the alignment and leveling procedures. In the lower photographs, we can see the case in a phase close to finishing procedures, with good interexpansion on the right side, the midlines almost matching each other, and on the left side, tooth 24 was already positioned in the region of tooth 22. In the final facial photograph, it's possible to observe the preservation of facial aspects with considerable improvements in the smile aesthetics. In the final intraoral photograph, it was observed a good interexpansion on both sides, obtained with molars in class 2 and canines in class 1, matching midlines and totally closed space. In the comparison of the initial photographs with the analysis 3 years after treatment, it's possible to observe that there was a great occlusal change and the results remained stable from the occlusal point of view with healthy tissues. The discussion addresses important aspects about biomechanics in cleft patients, important details in the decision to close or to maintain the space of absence in this case, and to correct or to accept the transposition in these patients. Finally, an important question are discussed regarding the limitations that case with cleft lip and palate impose on the progress and outcome of the treatment. Thank you.